Thanks for your comments, and now we will continue with task number 9, and that's the third part of the intervention 6 university credits. And just for your convenience here, I want to show you the PowerPoint show from the computer. So we can just turn over to the computer. Okay. Now to a comparison between two different programs, and my choice is make a comparison between lidcombe program and Carl Dell stuttering modification program, and those programs here for preschool children. First of all, a description of the lidcombe program. The lidcombe program, developed during 30 years in Australia, is an operant approach of stuttering treatment for children at the age between 3 and 6 years. The operant approach in treatment of stuttering is based upon single subject laboratory studies that demonstrated the efficacy of response contingent stimulation reduced stuttering to near zero levels in preschool children, and there's a reference to Concher and Curley. The lidcombe program is developed and conducted by the Australian Stuttering Research Centre within the Faculty of Health and supervised by Onslow at Allied. The lidcombe program, a description. The lidcombe program is a direct treatment for stuttering in preschool children. It is focused on the children's speech and not on family relationships, parenting styles, etc. During visits once a week, together with their child, the parents learn by the speech-language pathologist how to conduct treatment and measure their child's stuttering severity. The parents deliver treatment to their child on a daily basis during conversation and play. The fluency of speech is measured. The clinician is adjusting the speech measurements during clinical visits. The lidcombe program is conducted in 2 stages. Stage 1, goal, to eliminate or reduce the children's stutter to a low level. Stage 2, goal, maintain that reduction of stutter for a long period of time. During this period, the clinical visits fades away on a regular basis. The 2 child responses that are essential to implement is stutter-free speech and ambiguous stuttering. They are produced spontaneously without clinical instruction, and that is without any change to children's customary mode of speech production. The other 2 non-essential child responses are self-evaluation of stutter-free speech and self-correction of stuttering. And there are also some other things. It's the parental verbal contingencies, and that's a part of treatment where parents comment on episodes of their child's stutter-free speech and ambiguous stuttering. For example, by saying, "Those words were smooth, natural," or "Wow, what a fluency." Speech measures are made by the clinician as well as the parents. The clinician uses measures to prescribe treatment goals. And now to the other program on early intervention. The stuttering modification plan by Carl Dell. The Dell programs of early intervention. And now to the description. The original program by Carl Dell was primarily designed for school-age children with developed stuttering and not preschool children. The Dell model is also used in different direct treatment plans, hands-on, from speech-language pathologist programs for preschool children. For instance, the Mini-Kids conducted by Peter Schneider, University of Aachen, and a Dell version by Wästlunds Artevelde Hochschule in Ghent. In this paper, the aim is to describe the overall components of the direct hands-on approach. And the source here is a handout for the Dell approach by Wästlunds, European Clinical Education, ECSF. The Dell approach is designed for children between the ages of 2 years and 6 months of age to 9 years with stuttering. The therapist works by means of game therapy. Therapy is more modeling than speaking. The therapist and the parents acts as a speech model. There is a general speech model which is used all the time during the therapy sessions and at home. And there is a specific speech model which is used by the therapist to modify the stuttering of the child during the therapy. Some aspects of this specific speech model can be trained with parents so that they can use these at home as well. The general speech model is a natural way of conversation with no extensive talking, relaxed speech rate, tolerating pauses, using normal disfluencies, easy repetitions and easy prolongations. Self-talk and parallel talk. The therapist parents reflect utterances of the child by showing interest, that the child is understood, encouraging the child to speak on. According to Carl Dell, the therapist in this way shows a better, more fluent way than the stuttering of the child, to erase the influence of the stuttering moment on brain activity. Pseudo-stuttering is served as to stabilize a motor speech planning and the implementation of patterns to produce speech. And there's also the specific speech model. The specific speech model is a reflecting dialogue in which a therapist identifies and modifies his own pseudo-stuttering and the child's stuttering with a slightly simplified stuttering. A vital goal is to teach a child to understand, recognize and play with his stuttering by experimenting, and to modify and improve control gradually. And now to the comparison between the two programs. The two programs have different approaches to fluency enchanting techniques. The lidcombe program prescribing improvement of the already existing, in some extent, normal pattern for a smooth, fluent speech, in comparison with the other way, the Dell program prescribing improvement of control of speech patterns through pseudo-stuttering. Both programs incorporate the parents in treatment as well as maintenance of skills. Now to the advantage or disadvantage. Here there are discussions, and we in our group, we think that the speech language pathologists in general should have the ability of a choice between these two methods without any problem. So to see the advantages or the disadvantages with the lidcombe vs the Carl Dell approach is entirely up to you as the examiner to evaluate. Both approaches should have equal fair chance as support from our healthcare sector, as well as different approaches in stuttering treatment for adults, stuttering modification and precision fluency shaping. And now to the evidence-based research practice part and to the clinical support. According to literature, the lidcombe program has more evidence-based support than stuttering modification therapies. Most authors within the reference list proclaim therapies that strengthen a normal fluent speech as a best remedial factor for the young child. Firstly, they refer to the plasticity of the brain of young children and its possibilities for remedy or cure from stuttering. Secondly, they refer to the old Swedish maxim saying, small children, small problems, and bigger children, bigger problems. And here it was a little bit more, but it was 852 words in this part, but with the Dublin discussions included, it turned out to be 1137 words, and I hope that's okay for you. And now, finally, only the literature list. Here it is.